until it's exactly 9 o'clock. That's Pacific time. We are, in fact, on the West Coast. So we will get started in very few moments. But thank you all for joining. Okay, I think that it is 9 o'clock and we are going to get started. So welcome to everybody. Lots of people still joining, but we're delighted to welcome you to we were trying to remember what number this is. We think it's 11 or 12. We lost track, but anyway, the Kawasaki Disease Parent Symposium that we do every year, which is our way at the Kawasaki Disease Research Center of thanking all of the participants who have been a part of our research over the years, to the families that we've cared for, and to families who are distant in all other parts of the world. Thank you for joining us, and we hope that this is a useful way to spend your Saturday morning. So I am going to try to advance my slides. I am trying to advance my slide using the usual methods. Amelia, do you have control over this? Maybe let me stop sharing and we'll try that again.
I see your cursor moving.
It's not advancing.
Oh.
Amelia, do you have thoughts? Let me stop sharing again and we'll try sharing again. Let's try this. Okay, and then we'll try this. There we go.
Oh, you go.
All right. So housekeeping story here is that instead of using the chat, we would actually like you to use the Q&A button to register any questions. However, Professor Mimi Glaudet from the University of Colorado is going to be our moderator today. And she has pre-reviewed hundreds and hundreds of questions that were sent in advance. So many of those we will be taking, and then some of the new live ones. So let me introduce briefly some of our panelists today. Everybody's going to be speaking. So we've got Professor Jen Burney from UCSD, part of our climate team. Adriana Tremoulet is my co-conspirator in the clinical care of all of our Kawasaki disease patients and associate director of the research center. Professor Mimi Glaudet from the University of Colorado is going to be moderating the session in terms of the questions. Kate Davila is our wonderful KD Foundation board member. Professor Neal Halsey is going to share a doctor's experience of being a patient with us. Kirsten Dummer is the newest member of our KD team here in San Diego. She's peds cardiology, and we're thrilled to have her joining our team. And Lucia Acosta is our fabulous Spanish translator who has volunteered to do this for all of our Spanish-speaking participants. So thank you so much to everybody. Just a brief agenda. I'm going to be going first, then Jen is going to follow up with our climate story. I'm coming back to talk about SARS-CoV-2. I think it's the elephant in the room that all of us are dealing with. Dr. Tremoulet is going to talk about treatments and a lot of the advances and exciting news there. And then we're going to have a half-hour question and answer period. So that's really to address the questions that you've submitted and the new ones coming in the Q&A. There'll be a brief Zoom break, just 15 minutes, and then we'll start up again with Kate Davila from the KD Foundation. Dr. Halsey talking about his experience of Kawasaki disease. Dr. Dummer will be talking about some new advances for treating children and adults who have had aneurysms, and then another half-hour Q&A session. So again, welcome to everyone. I'm Jane Burns, and I'm the director of the Kawasaki Disease Research Center. I show this slide every year to give you a sense of what happens at Rady Children's Hospital, and you can see that in most years, we have between 80 to 100 new Kawasaki disease patients, except for what happened in 2020. And I'm not going to speak any further about that amazing event, but Dr. Dummer is going to focus on that in her discussion from a climate scientist perspective and an epidemiology perspective about what happened. So I want to share with you some exciting news that we have about diagnostic tests. I know for all of you who had children where the diagnosis of Kawasaki disease was not made immediately, this was a huge frustration. It continues to be a huge frustration. And in many parts of the country, delayed diagnosis of Kawasaki disease is still a big, big problem. So we have some help on the horizon there. New clues to etiology, perhaps, for Kawasaki disease, Professor Burney is going to talk about, and new treatments with Dr. Tremoulet. So biomarkers have been a search for the last 40 years, and biomarkers are basically things that we can measure in the blood or saliva or urine or tears that can be a signal that tell us about what's going on in the patient. And we have chosen to really focus, instead of at the protein level where we can measure proteins, molecules in the blood of our patients, we've chosen to focus one step back in the molecular biology sequence here and focus on messenger RNA. This is a way of almost looking inside the brain of a cell to see what the cell is up to and what it's doing. And this has turned out to be very productive. So we shared with you this information. In fact, Professor Levine, who's shown here at Imperial College in London, was a speaker at our last symposium. And he shared with you the work that we had been doing to collaboratively. So the blood from your children here in San Diego went to London, and there it was put onto an array, which is a technology that allows us to look at many, many different messenger RNA molecules at the same time. And we came up with a panel of 13 different molecules that made a signature that were, when the red ones that you see here were up and the ones that are blue were down, that was seen when children had Kawasaki disease, whereas when they had fever for other reasons, there was a different pattern. So we were excited about this in 2018, but the question was how to take it to the next step. And fortunately, a company in Holland, Skyline Diagnostics, stepped up to the plate and worked very diligently over the last year to transfer the technology that we had used to discover this into a platform that can eventually be adapted to a machine in a clinical laboratory in a hospital that with a 1-hour turnaround time could give us an answer. So we're still in the middle of this transferring process. We're actually at this stage here for validation, and 500 samples from San Diego are soon going to be making their way to Holland, where these samples will be tested to validate the original discovery that was made. And similarly, many blood samples from around Western Europe and the UK will also be sent to Holland, and there will be a parallel process. So we're optimistic. It's never done till it's done, but the potential is really there on the horizon of having a very robust 1-hour turnaround test that could be put into clinical laboratories. Another way of looking at this problem is to say, how could we just use the standard laboratory tests that almost any child being evaluated for fever and being very sick might get in an emergency department, basically anywhere here in the United States. And so we were joined with Shamim Namadi, who's the director of predictive analytics here in the Department of Biomedical Informatics at UCSD, and his graduate student, Jonathan Lamb, who are taking a different approach. And that is, let's see if we can teach the computer to analyze a few clinical features of the physical exam and the very standard laboratory tests that any hospital or really any clinic could generate. And let's see if the computer can be smarter than we are. So this is this whole new era that we've entered into of artificial intelligence and machine learning. And this is a schematic of how they're trying to teach the computer to do this. So they were seeking to develop an algorithm, a sequence of thoughts in the computer that could identify a child with Kawasaki disease and differentiate that child from the new kid on the block, which is the multi-system inflammatory syndrome. I'm going to be talking about that later. It's a complication of SARS-CoV-2 infection. And it has some similar characteristics with Kawasaki disease. So first, the computer was trained to try to sort out these MIS-C children. And then it was trained, once it sorted those children out, then it was trained to try to understand who had Kawasaki disease versus a fever for a different reason. So there were really 3 groups of patients: the febrile controls, the Kawasaki disease patients, and the MIS-C patients. And we'll just cut to the chase here and say that in our initial training and testing exercises, the computer was 96.7% accurate in understanding who had MIS-C versus other things. And then moving on to other things versus Kawasaki disease, the computer was 89% accurate. So the team is now in the process of validating this, externally validating this with lots and lots of other patients from other institutions around the United States. So we have Boston and Washington, DC, and Denver and other places that are being used, also Children's Hospital of Los Angeles. So thank you to all of the collaborators who are contributing their cases to try to make our computers smarter and smarter and smarter. And the idea is that this could be used to support physicians in emergency rooms around the country who get initial laboratory data, have a few physical exam findings, and put that into a computer. There are actually 18 separate features that they would type in, and the computer could tell them the likelihood of the diagnosis. So along those same lines, there has been a team working with Dr. Tremoulet, and particularly this is work that was spearheaded by Ellen Zhu, the sister of one of our patients, and a team of students, and now joined by Jonathan Lamb and Shamim Namadi, who are using photographs of patients, again, for facial recognition, teaching the computer how to recognize what's Kawasaki disease versus what is MIS-C or just other sources of fever. So this is a QR code. If you would scan it and you have photographs that you would like to contribute to our research, We welcome you, and we would be very grateful if you would share your photographs. And finally, the long-term outcome study, another way that you and your children can participate in the ongoing gathering of information and understanding long-term outcomes for our Kawasaki disease patients. If your child is 15 years or older, or you are an adult who had a history of Kawasaki disease, please contact us through this email address. It only involves an online detailed health questionnaire and then a follow-up questionnaire for 20 years that we send to you via your email every 2 years. And this is the only way that we're going to understand long-term outcomes in Kawasaki disease. And we're super grateful, and a shout out to Don and Patty Dawn and their daughter Brooke, shown here, who have now breathed new life into this long-term study, as well as through the Macklin Foundation, their private foundation, funding several more projects here at the research center that we hope are going to address all of the unmet needs for diagnosis and long-term outcome questions in Kawasaki disease. And finally, if you want to join with the Dawns and donate to our research efforts, we're always happy to hear from you. And Amy Weeks is our wonderful development officer at the Rady Children's Hospital Foundation. She can be reached through the email shown here, and we would love to hear from you. So I am going to stop sharing there, and we're going to move on to Professor Burney, who is here, and I will mute myself. And Professor Burney, take it away.
Excellent. Good morning, everyone. I will take one moment to get situated. I want to make sure that I can see our translator, Lucia. Great. And I also want to make sure I can see the chat if any questions arise. All right, well, good morning, everyone. It's really a pleasure to be here. I am a faculty member here at UC San Diego, and unlike the rest of this esteemed Kawasaki disease team, I'm actually a physical environmental scientist, and our team is working to try to understand what the clues about where and when Kawasaki disease occurs, what clues that give us about its etiology. So what are the triggers that cause Kawasaki disease, and how can we find them in the environment? We think they're environmental aerosols, suspended particles that are inhaled and that trigger this cascade of symptoms, but really what the trigger is and how we can better hone in our search is our focus. I want to start by just saying thank you to this special group. Your children who fall sick tell us about where KD was present. So in addition to being patients, they're sort of a broad sensor network in some ways. And so understanding the detailed records of your individual cases of who falls ill and where and when they were, this helps us understand the patterns, and we think we're making progress. So I know none of you would ever choose to be part of this club, but we're really grateful that you are so helpful with the research. So thank you so much, even in your own process, for being part of this collective. Our goal here is really to understand the environmental conditions associated with the Kawasaki disease triggers. And so we use these data, and particularly understanding exactly when symptoms started and what kinds of symptoms and what kinds of lab values children have to learn about what they've been exposed to. But the interesting thing recently, I'm going to be talking about this more recent time, is that there's been a huge behavioral change societally during the pandemic, and that helps us untangle some of the environmental components that might drive Kawasaki disease from all of our behaviors that lead to sort of what we're exposed to in the environment. So let me just show you some figures that describe what has happened to Kawasaki disease over the COVID pandemic. So this is the total of KD cases across the 30 kid care sites in the United States. And some of you might be listening, so thank you again for participating. This dotted line shows the total number of cases across these sites in 2018. The solid light blue line is 2019. And then you can see that in 2020, the year starts off, there's a bit of a blip. I'll come to that in a moment, but then really Kawasaki disease kind of drops dramatically as the sort of pandemic emergency orders go into effect. So we're not totally sure about this blip. Kawasaki disease was already low by March, which is typically a peak here, for example, in San Diego. This peak in May may be some MIS-C that, remember that was also a new disease, may not have been correctly identified at the time. We're still trying to understand this. Here in San Diego, we have, an even longer set of data of dates of onset. Many of you now adults in the adult study, so thank you again. This light blue line shows the average case incidence by month in San Diego from 2002 to 2019, and then the spread around that. So this is sort of the usual pattern. And again, in San Diego, we see a similar pattern where in 2020, we really see KD rates fall well below what would be expected. And then in 2021, the first half of this year, rates stay very, very low and then come back up. A couple of data points. The California emergency declaration was at the end of February. And really we see behaviors start to change, people starting to work from home, buy lots of toilet paper, come back to their houses more, out less. In early March, and by mid-March on the 17th, that was the shelter-in-place order started. So right around March 17th is when really, schools shut that week, et cetera. By April, the sort of mid-late April is when the mask mandate went into place. Remember at the beginning, we were sheltering in place, but we weren't necessarily masking. Mask mandate goes into place. And then around June of 2020, the shelter in place lifts, but everybody really is, things are not fully back open, but people are out and about a little bit more. In 2021, April, very beginning of April is when all adults become eligible for vaccines. Many have gotten them up to that point, but really that's when vaccines are available, and we get the quite early order from the CDC, though, saying that if you're vaccinated, you can be sort of out and about and living more freely prior to sort of Delta taking over again. So just noticing what happened, right? These behavioral changes really coincide dramatically with this downfall in Kawasaki disease. And so we're trying to understand what that means. But important thing to note is that KD didn't disappear entirely. So here's a little figure. It's a little bit noisy, but we've got a bunch of different types of illnesses seen in San Diego at the same time that KD was being seen at Rady Children's Hospital, and that's shown in black is the Kawasaki disease. But the shelter in place, this gray bar that starts in early March, that period is shown here in gray, really shows everything else like rhinovirus, flu, other stuff just disappearing entirely. And KD didn't really do that, right? It slowed way down, but it didn't go to zero. So that's also an important clue. But we do know that the behaviors really did result in a big change. And this has really reinforced this idea that it is something inhaled that's floating along in the air. I'm going to give you just some statistics of what we've learned about who did or did not get KD as much during the pandemic. So just to orient you here, the light blue line, again, these are all data from San Diego. The light blue, again, is the historic kind of comparison, 2002 to 2019. The dark blue columns are the totals for 2020, And then that's broken into a few periods. The light green is before the pandemic. The dark green is during the real intensive shelter in place period. And then the pink is the rest of 2020. Then red is the first half of 2021. And what I'd like to draw out here is that while KD was down really across the board, it was down far more for our Asian and Hispanic children. So really a disproportionate reduction. We see some other interesting patterns by age, again, down across the board, but really it's these younger age groups where the totals for 2020 are very, very low, and where especially for these 1 to 5-year-olds, the beginning period, the shelter in place period is extremely low. Another interesting fact about the Kawasaki disease during the pandemic has been that the ratio of male to female children has changed as well. So typically we have about 2/3 male children out of all the kids who fall ill. In 2020, the number of males to females dropped quite a bit. And it has come back up in 2021, this red bar again, but it was fairly dramatic to have that fall below half, and that's well outside of what would be expected. So really interesting is that the biggest reduction was really younger and predominantly more male patients who would have gotten sick in ordinary times, but did not fall sick during the pandemic. When we look at lab values, there are not a lot of large differences. I put a lot up here, but what I want to draw you to is that there's not a lot of large differences between, and in some cases, really no statistical difference between Kawasaki disease sort of prior to the pandemic and the type of Kawasaki disease that has been seen during the pandemic. However, when we look at the sort of clinical presentation as opposed to lab values, there have been some interesting changes, right? So again, the blue bar is the historical kind of 2002 to 2019. The dark blue bar is all of 2020. And what we're really looking at is the dark green and the pink are the pandemic period of 2020, and the red is now back to 2021. We see that strawberry tongue, the incidence of strawberry tongue really dropped. Fewer patients had this, far outside what would have been expected. And that was different between the pandemic period and the pre-pandemic period. Similarly, for having the pronounced lymph node, that fraction of patients really dropped in 2020. It seems to be back in 2021 now. And peeling dropped way, way, way down and has not fully come back yet. So some really interesting, very dramatic changes outside of our sort of historical experience here with Kawasaki disease. One of the types of analysis we've been doing environmentally has been to try to understand what people are doing, how much are they out and about. So let me explain this to you. These red and black lines are patterns derived from cell phone information that tell us how much people were away from home during the day. And the black line is from neighborhoods that had no Kawasaki disease cases. And the red line is from neighborhoods that did have Kawasaki disease cases during the pandemic. And then this is a time series from 2019. People are away more during the week and home more during the weekend. And this sort of, on average, people are gone about 50% of the time. And then when we see the pandemic hit, that really drops. Everyone follows the orders and shelters in place. And then we recover back, but not really to pre-pandemic levels. These blue cases are dates when we saw Kawasaki disease cases in San Diego at Rady Children's Hospital. And so you can see that frequency drops way down. But what I want to draw your eye to is that there's really not a large difference between sort of neighborhoods where there was KD or not. And if anything, KD was occurring more in neighborhoods where people stayed home a little bit more prior to the pandemic, but very small differences afterwards. The geographic distribution of cases changes a little bit. Prior to the pandemic, most cases were kind of central San Diego. In the initial shelter in place period, the bulk of the cases are further north in the county. As sort of stuff partially opens up, that moves back down. And now back in 2021, our distribution looks a little more like the historical norm. So again, really stuff moved. And that's a function of, largely behavioral changes, probably changing exposures, though we are also looking at the associated environmental conditions. Oh, apologies, I meant to draw those out. One thing we see is that, as you guys know, Kawasaki kind of doesn't really discriminate in terms of income. People are susceptible all across the income spectrum, but we did see that during the pandemic. So historically, prior to the pandemic, the income distributions of neighborhoods that did or did not have kids with KD were really very much the same. They lined up almost perfectly. This stripe is kind of the middle of the distribution. And over the pandemic, that actually shifts, where we actually saw a shift of typically kids from slightly wealthier families were the ones getting KD. So there's just very interesting geographic changes happening in disease incidence. So I will stop there. My time is up. As always, it's really a pleasure to be here and an honor to be here. And thank you for participating in this so we can find the cause of this disease.
Dr. Barnes?
Great. I am up next and I will share my screen. Thank you so much, Jen. That was great. Okay. We're getting there. Okay. During the pandemic, we pivoted to becoming the team that also took care of children who had the inflammatory complication of exposure to the coronavirus. We did not take care of the children who had pneumonia and the typical kind of COVID-19 disease, but we took care of this other group of children. And we're going to talk a little bit about that and how the coronavirus affected children and what you can do to protect your children from this virus. So first of all, the majority of children, particularly early on in the pandemic and before we had the Delta variant, which changed the calculus, these children could become infected with no symptoms. They were perfectly happy, but they were spreaders of the virus. And there's no question that within households, they could spread the virus to other more susceptible individuals living in the household. The Delta variant changed all of that. And we began to see children in the hospital with pneumonia, needing oxygen, needing to go onto a ventilator, and having the same kind of COVID-19 disease that we saw in adults. And then a very evil manifestation of this virus, which we began to recognize back in 2020, really at the beginning of the pandemic, was the multi-system inflammatory syndrome in children, or MIS-C. This remains a rare condition with only 4,600 or so cases reported in the United States, but it occurs 2 to 6 weeks after the child has been exposed to SARS-CoV-2 infection. Now, that child may have had no symptoms at all of that initial exposure. There might have been a family household history of COVID-19 and a suspected exposure of the child, but Many of our patients have come in with the parents saying they had no idea where the child could have been exposed, but they were exposed. We can see evidence of that by measuring antibodies in their blood. And these children present with a very severe illness that initially tends to involve fever, abdominal pain, with or without vomiting, with or without diarrhea. But the really serious complication is heart failure and low blood pressure, which we call shock. And many of these patients, about 80% of them, can end up in the intensive care unit requiring very significant support to maintain their blood pressure. Now, why did we get involved with MIS-C patients? Well, here's what MIS-C patients can look like. And you can all recognize as KD parents that there was a significant overlap in terms of very sick children with fever presenting with dry, cracked lips, with the bloodshot eyes, and the nonspecific rash. Now, not all MIS-C patients have this, but they can. And so the overlap with Kawasaki disease was quite obvious. So we're going to address now how you can prevent the spread of the virus. And full stop, most important issue is get vaccinated. Everyone who is age eligible should be vaccinated. If you wear masks indoors, as Professor Burney just showed you, we stop not only Kawasaki disease, but we stop the spread of the virus and all of the respiratory viruses that commonly circulate, particularly as we go into the winter months and particularly now that the children are back in school. They need to be back in school as pediatricians, as parents and grandparents. All of us on our team strongly, strongly urge you to get your children back into school. They need this for their emotional and mental health. It's so that the parents can go back to work. It has a number of repercussions throughout society. And these children, we feel, need to be in school. But masking is a very viable way to protect them and should be followed. If someone in your household develops COVID-19 infection with the SARS-CoV-2 virus, then they need to be isolated, and they need to be isolated for infected children or adults for 10 days after the onset of symptoms or after their first positive test if they had no symptoms. How can you protect your younger children who are not yet eligible to receive the very safe and very effective vaccines that are available for our adults and older children? You can cocoon them. And by that we mean vaccinate all the eligible household members. And that way you can protect the youngest children who are not yet eligible for receiving a vaccine. We have learned a lot during the pandemic, and there were false steps at the beginning, but we now have absolutely understood that the virus is transmitted through two kinds of aerosols. One of them is the large droplet when you cough or speak or sing. And those big droplets fall out of the air but can be on surfaces, so that's why we've been washing our hands. And then airborne transmission is why we are masking. So the children can be protected not only from SARS-CoV-2, but from all the respiratory viruses by masking. They actually tolerate it very well. And exercise is absolutely safe for them while they're masked. There is no contraindication. There were some spurious reports of children having respiratory problems if they were masked during exercise. That turned out not to be true. And it is absolutely safe for them to mask and exercise. Questions have come up from our KD patients across the country who have reached out to us. You've all been told that you shouldn't vaccinate your child after receiving IVIG with live virus vaccinations. However, the SARS-CoV-2 vaccine is not a live virus. It's a tiny bit of the nucleic acid, the genetic information from the virus that is contained in the vaccine. It's not alive. It doesn't do anything that a live virus would do. And it's absolutely safe to get it after your child has received IVIG. So if your child had Kawasaki disease, received IVIG, yes, they can be vaccinated. And they should be vaccinated if they are in an age group that is currently recommended for vaccination and for whom vaccination has been shown to be safe and effective. Many people have reached out to us with questions about a heart complication that is extremely rare in teenagers, mostly boys, seen after vaccination with the SARS-CoV-2 virus. So this is called myocarditis, which means inflammation of the heart. And it remains a very, very rare complication. And we wanted to present to you some of the calculus, if you will, about the pros and cons if you're worried about the myocarditis. This was from a large analysis that was published in the journal Circulation. For every million second doses of the vaccine, there could be up to 80 cases of myocarditis. That's 80 out of a million children who are vaccinated. If you didn't vaccinate that same group of children, the 12 to 17-year-olds for whom the vaccine is now encouraged and safe and recommended, if you did not vaccinate them, we can predict that there will be 17,000 COVID-19 cases. That comes with all of the horrible complications potentially of what's called long haul COVID, which is a poorly understood but devastating fatigue syndrome that can follow on with the acute infection. These children can lose their sense of taste and smell that may or may not come back. In that same group, there would be an estimated 266 ICU admissions, very sick children requiring ICU care, and 2 deaths. So that's what we want to prevent, and you can prevent that with a vaccination. So again, a strong, strong urge to get your children vaccinated if they're in the appropriate age group. So should you vaccinate your child? Yes. If your child is between the ages of 12 and 17 years, yes. Now we are expecting recommendations to come out that will only come out when the data are clear and when it is known that it is safe and the dose adjustment has been made for younger children. We're awaiting those recommendations. Please check the Center for Disease Control website. And obviously it will be in the media when that's approved. Should you vaccinate your child who had KD, whether or not they got aneurysms? Yes, it is safe for your children. Kawasaki disease children are at no greater risk, but at no less risk of the infection with the virus and all the potential complications. So yes, you should protect them. And if your child has aneurysms, they should not be allowed to get COVID-19. That could be dangerous for them. And yes, they should be vaccinated. And if your child did not have Kawasaki disease, but had MIS-C, they also need to be vaccinated because it turns out that natural infection with the virus is not protective in the long term. That protection that you get after natural infection or after MIS-C disappears over a period of months, and those children should be vaccinated. So I hope I've put my plea out there clearly and in the simplest possible terms, please protect your children. The only way we are ever getting out of this pandemic, if you think this virus is ever disappearing, you are wrong. It is never going away. We hope it gets down to the level of the kind of seasonal influenza or other viruses for which we can be immunized perhaps every year to protect ourselves. But the only way we are getting out of the current situation is for everyone to get vaccinated. And now I'm going to turn it over to Audrey.
Hello, everybody. Thank you so much for joining us. I'm going to be addressing the treatments of Kawasaki disease and MIS-C and what we have learned over the last year. First, we're all familiar with the standard treatment for Kawasaki disease, including intravenous immunoglobulin and aspirin. And so we have some exciting science to share with you that actually was just published. And this is regarding the role of IVIG and how it works. And with the work of Ben Croker in his laboratory, he's been able to demonstrate that there's a particular cell shown here called the neutrophil, which is a very important inflammatory cell in Kawasaki disease. And that IVIG, in fact, appears to be killing these inflammatory cells. And that may be in part the mechanism for how IVIG works and boosts the normal immune reaction to Kawasaki disease. So it's very likely that this is a key mechanism for how IVIG is working. We're thrilled to share with you that just this week, this work made the cover of a very prestigious journal, the Journal of Clinical Investigation. And you can see there a molecule of IVIG. And this work, intravenous immunoglobulin in Kawasaki disease and MIS-C, is our work that we were pleased to be able to publish this week in that journal. And here is a brief capture of what we were seeing. So on the graph there on the left, you see black, which are predominant, and that predominant black are all the live cells. Those are cells that are alive. This is work being done in the laboratory. And there is no IVIG in the dish that these cells are in, and the majority of the cells are alive. And then when IVIG is added to that same group of neutrophils, those same inflammatory cells, you see that you now have many less that are black and more that are blue, and these are dead cells. This is one of the things that we were able to demonstrate in terms of how IVIG is killing these inflammatory cells that are causing the inflammatory cascade in Kawasaki disease. So that is really important information for the mechanism of IVIG. What I'd like to move on to is that IVIG is not the answer for all of our children, especially for those with fever persisting after receiving IVIG. Those are termed IVIG resistant patients, or those with coronary artery aneurysms despite receiving IVIG. So for those that have been with us in the past, you're aware of the number of studies that we've been leading to try to find better treatments for Kawasaki disease for those children affected with coronary artery aneurysms and IVIG resistance. And before I go any further, just a huge thank you to all of our families, where when you are just being admitted to the hospital, in many cases, you're just meeting our team, you're just understanding this disease, and you're willing to participate and to confide in us and to share samples and share data so that we can learn how to better treat Kawasaki disease. So the issue that we have currently with KD is that there is no treatment to stop the progression of aneurysms, much beyond what exists already with IVIG. We can follow echocardiograms for the progression of coronary artery abnormalities, but we really need to have additional therapeutics available. And that's really what our team for more than a decade has dedicated themselves to, is really trying to find new treatments that we can use. These are treatments that are used for other indications in children. Many are already approved in children, but they've never been used in Kawasaki disease. And we've been bringing these drugs over to our side of Kawasaki disease based on the science that we've done that has shown us that there are mechanisms that these drugs have that can block key parts of the inflammation in Kawasaki disease. So I shared with you last year some information about the statins that are used in adults and in children. And I showed you data about that in Kawasaki disease. The statins are only approved, and we only have the ability to use them in KD down to 2 years of age. We've now recently been allowed down to 1 year of age. But it turns out that many of our children that have issues with Kawasaki disease, that have aneurysms, are in fact in this left side of the screen. They're less than 6 months of age. And that is demonstrated by these graphs. These are coronary artery abnormalities in KD patients treated in the first 10 days of illness. These children have not been missed, they have been treated. And you can see that in yellow, in pink, and in red, those are all dilated and aneurysmal findings of the coronary arteries. That takes up more than half of the graph in these less than 6 month old babies, as compared to children greater than 6 months old, where it's really still a substantial number at a quarter of the treated patients. But in fact, we need treatments for kids that are much younger than a year of age. And so this is where a different medication came into the conversation with us for Kawasaki disease. So we took a medication called anakinra, which is approved in children. It's approved down to birth for some inflammatory disorders in children. And in collaboration with Boston Children's, we launched a study to see how safe anakinra was in our patients, and to really understand the pharmacology of the drug. This is a drug that is mostly given underneath the skin. It's called subcutaneous, with an injection given under the skin. But we wanted to also see how it would work if you give it through the IV. So first of all, in regards to safety, we actually evaluated and found that it was very safe in young children. We had children as young as 2 months of age in our anakinra study. And really no kids had any issues with anakinra in terms of its safety. This is in a study that we did. It was small, albeit we had 22 kids, but it's the only study that's been done to look at using anakinra to treat aneurysms in Kawasaki patients. And then, as I mentioned, we compared giving it through the route of injecting it under the skin versus giving it IV. And what we did was we evaluated the pharmacology of the drug. And you can see here a representation on this lower left of the drug being absorbed and then being eliminated by the body over time. And we did that evaluation in our patients, looking at the absorption of the drug and then being eliminated over time. And I'm proud to share with you, and a big thank you to all families on the line that will be listening to this at some point, that were part of this study, because this is really the only IV drug information about anakinra, not only in Kawasaki disease, but really in any disease. And so we didn't really realize when we were doing this study how important this would become, because as it turns out, this is now one of the drugs being used in the multisystem inflammatory syndrome in children, in MIS-C, that Dr. Burns just spoke about. And the data on how to use this IV for the world came from our group and this study. So with that, I'd like to move on with additional treatment trials that are going on for children with Kawasaki disease and coronary artery aneurysms. Last year, I spoke to you about the use of statins, which are used routinely in adults and even in some children. But in those patients, it's used for lowering cholesterol. That's not what we're looking for here. It turns out that the statins are a really interesting group of drugs, and they actually help the inside layer, the endothelium of arteries, heal. So what we're trying to do by treating children with Kawasaki disease with aneurysms with statin is to have that endothelial healing. And so with the information that we have from the statin study, as well as the anakinra study, we are now using these drugs in combination. And thus far, we have enrolled 5 patients to date as part of a combination trial. This is part of a larger study that's being done, that's funded by the NIH, to look at the science behind this combination treatment, both using studies that are being done in the laboratory and as well as in the patient. And we are learning what the combination of these 2 drugs do. And we hope to have future information to you at other KD symposiums with the results. But at the moment, we're currently enrolling. So if you arrive to Rady Children's Hospital with acute Kawasaki disease and coronary artery aneurysms, our children down to 1 year of age are now eligible to have this acute treatment study, where we're giving atorvastatin for 6 weeks, and anakinra is administered for up to, it's between 2 and 6 weeks of treatment, depending on the severity of the heart disease. So I'd like to introduce you to a new study that we're doing called the PEACH study. This is also a treatment study with atorvastatin, and this is promoting endothelial cell health after Kawasaki disease. This is a picture of what I was just talking about, the endothelial cells that line the blood vessels of the heart. And so we have demonstrated that atorvastatin, which we've tested in our Kawasaki patients, is safe and that it helps in the healing. And so we started a new study where we actually are studying children with long-term aneurysms in this PEACH study. So let me share with you who is eligible. So KD patients that are cared for at our hospital at Rady Children's that are at least 8 years of age with a history of medium or large coronary artery aneurysms. We are currently working on reaching out to these families, and when you come to clinic, we'll be discussing this with you if you're eligible. What we're asking for is consent and assent of these children and consent from the parents to blood draw. A study called EndoPAT, which is what's shown here on the left. This is looking at the cell health, these endothelial cells, how healthy are they? This requires having you sit in a chair, a blood pressure cuff gets put on one arm, there's a little probe that gets put on the finger there. Then the blood pressure cuff is inflated and held for about 5 minutes. And then it's deflated, and we're looking to see the response from the endothelium at the level of the finger here, monitored with this probe. I've actually sat in this chair and had this done. I believe in everything that we ask our kids to do, we should do ourselves as clinicians. I will say that it was a little uncomfortable to have the cuff inflated, but there was nothing scary or really painful about this process. So that's what EndoPAT is. And then some of our patients were also now have a really fast CAT scan that can be done at Rady Children's. And so we are having CT scans done of the heart that frankly we would otherwise do in all of these children just for their general care. But we are asking for your permission to use the data from those CT scans to be able to learn. So those kids that have these medium or large coronary artery aneurysms that are still ongoing, given the safety data from the studies that we've done, we are now starting those children on atorvastatin and watching and seeing how they do with the EndoPAT study over time. So now I'd like to switch gears for a moment to the newer disease that we've been treating that Dr. Burns mentioned, which is MIS-C. So on April 27th of 2020, when the National Health Service in the UK first announced this illness, you can imagine that since it looked like KD, our inboxes, our email, our phones, everything just blew up with questions about how to treat this disease. in all honesty, a disease that Dr. Burns and I had never seen, but everybody was grabbing for what they knew. And what everybody was familiar with was IVIG for Kawasaki disease. So that has become the standard initial therapy. Now, as Dr. Burns mentioned, most of these children are very ill. They're in the intensive care unit. Their heart is not pumping well, so they need more than IVIG. And that's closer to 80 to 90% of kids need something more than IVIG to control the inflammation. And it turns out that depending on where you were, because this disease was being seen first on the East Coast and Midwest before us, depending on where you were, you got a different kind of secondary treatment. And these treatments may sound very familiar, especially to our Kawasaki families out there, because we have studied infliximab and anakinra, as I just shared with you. And on the East Coast, where they use steroids a lot for Kawasaki disease, they've studied a lot about steroids. So depending on where you were and in which city, if you were in New York, you reached for steroids. If you were in DC, you reached for anakinra. And if you were in Detroit, you reached for infliximab. And that's what became standard at all those sites for children with MIS-C. Now, we decided to take a slightly different approach than to use what we've used as a standard for KD, refractory therapy. And if you were here, we would have used infliximab. We did do that initially, but we learned quickly that really nobody knew what the right treatment was for MIS-C. And frankly, I will say that still using the present tense of the verb, nobody knows what the right treatment is for MIS-C. That's called clinical equipoise. That means we don't know which treatment is better, treatment A or treatment B. So because of that, we decided to launch a study. And so we launched what we call the MYSTIC trial, which many of your children may have been in if you've had MIS-C and you were with us since December 20th. That's when we launched this just right before Christmas. And it was a huge thank you to our team here for very quickly launching this study. All children receive IVIG. If you do not respond, if you're in the ICU, if you're critically ill, you go on to get randomized, this yellow R, to get either infliximab, steroids, or anakinra. And if your child is still not doing well, still in the ICU with increased needs of medications to help the heart pump, or the inflammation's going up, or the arteries of the coronaries are getting worse, then you randomize, or fever, I will add as well, some children are very febrile. Then you go on to randomize to one of the other two drugs that you have not had yet. And thus far, we have had nearly 40 kids in this study, and we are grateful to all of you that, again, during the most dire of times, have agreed to be part of the study and contribute your child's information and allow us to randomize your child to these different treatments. So finally, I'll just end with what I've been saying all along. This takes a village. I have the great honor to be leading a lot of these therapeutic studies, but this is not at all done alone and in a vacuum. It's done with the help and trust of our patients and families, all the team members that we have, from everybody that's in the lab that collects the data and processes the samples, to everybody on the clinical and treatment teams. And so a great thank you to all. And with that, I will end. Thank you so much. I'll just add a final thank you here for the Wormers Family Foundation, who is currently funding the PEACH study, and to the National Institutes of Health for the treatment trials that are ongoing and that have been funded. Thank you.
So thank you, Audrey. And we are going to shift now over to our moderator, Dr. Glaudet, who is going to direct questions that have either come in through the chat or through the Q&A and were also submitted previously. And she's going to call on all of the panelists to field your questions. So I will mute myself and wait to be.
Okay, can everyone hear me all right?
Yes, we can.
Okay, there we go. Okay, thank you very much. Well, you can imagine that we received a lot of questions. We had over 200 questions in English and Spanish. And as all of you know, this symposium includes participants not just from the United States, but from many other countries, including Australia, Canada, the UK, Europe, and Latin America, and probably a few other ones. So welcome to all of you. The time that we've allowed for we have two question and answer sessions, and this one will run from 10 to 10:30, and then there will be a Zoom break from 10:30 to 10:45. And then we'll resume at 10:45 with additional talks. So of the over 200 questions in English and Spanish, there were about 4 or 5 categories that seem to cover most of the questions. And I'm just going to mention those categories, and then we're going to ask a few questions from them of our speakers. So COVID and Kawasaki disease, lots of issues there. Treatment of Kawasaki disease, the cause of Kawasaki disease, family issues, siblings, risk of Kawasaki disease in family members, and then of course the long-term effects. So we've talked about a number of these issues from our speakers, but I'm going to bring up some of these questions and they can help us a little bit with that. So Jane has covered extensively, I think, Dr. Burns, that COVID vaccines are safe for kids who've had Kawasaki disease, and it's very important to get them immunized if they're age eligible. And as you know, we're moving the ages down and doing studies in younger and younger children of these vaccines to assure that they're effective and safe in young children. So let me start with a question for Dr. Burns. Dr. Burns, children who've had Kawasaki disease and then later go on to get COVID infection, how are they doing? What do we know about them? Are they handling that infection okay?
I am unmuted. So the question is, what happens after you've had Kawasaki disease?
What happens after you've had Kawasaki disease, and how do you handle other infections? And although there were a lot of questions that came in about what is the effect of Kawasaki disease on the immune system, does it have any long-lasting effects? We have not seen that. And the current information that we have, which is, albeit incomplete, is that children who have had Kawasaki disease go back to being normal with respect to handling future infections, to handling future vaccinations, to handling any insult that comes along to the immune system. But I want to emphasize, and this is my opportunity to beg and plead for everybody who's 15 years of age or older to join our adult KD study, because honestly and truly, this is the only long-term outcome study being done on Kawasaki disease patients. And to really be able to answer that question, we need to be able to follow these young adults and learn for sure that they are or are not having some unusual health problems later on. Right now, there is no signal that that is happening, although we have some question about a signal that's emerging about migraine headaches and an association with Kawasaki disease. But these are the kinds of things that we can only learn by having as many people as possible participate in our long-range health outcome study. So again, I wish I had a more perfect answer, but based on the information that we have, everybody handles infections subsequently just fine. And there were questions about how do you handle COVID-19 infection, the SARS-CoV-2 virus, if you had Kawasaki disease. And while I can't quote you exact numbers because no one is gathering those, we certainly have had the experience during the pandemic of seeing our Kawasaki disease patients in follow-up. Unfortunately, many of them have had either COVID-19 or known exposure to the virus with PCR positive testing. And they have all come through just fine, not different, it would seem, than generally children of that age group. So there is no signal at the present time that Kawasaki disease children, by virtue of their genetics that gave them Kawasaki disease or made them susceptible to the trigger of Kawasaki disease, there is no signal that says that they are going to handle COVID-19 better or worse than any other children. That's my answer.
Okay, thank you very much. Can you have, and I guess, well, let's go to this question. Is it possible that a child diagnosed with Kawasaki disease in early 2020 actually had MIS-C instead? What are we doing about the confusion with trying to deal with separating those diseases? And you could start, Jane, and Audrey could chime in and as well.
Okay. So
The the question of confusion is clearly why we need the diagnostic test. And that's why I talked to you about the research that we're very, very actively doing to give people a definite diagnostic test where we can stop the confusion. So there's no question. And Professor Burney showed you in that graph that there was that blip, do you remember, in May? And all of us on the team strongly, strongly suspect that that blip was not Kawasaki disease. It was confusion with the emergence of a brand new disease that no one on planet Earth had ever seen before, and that was MIS-C. Because of that overlap of the clinical signs, very sick children with fever, red eyes, rash. So we are really hopeful that the research that we're doing with the help of parents and the fabulous teams that we're collaborating with are going to solve that problem of the confusion. But I do think it's possible that if your child was diagnosed in early 2020, it is possible that their MIS-C diagnosis was confused with KD, or their KD diagnosis was confused with MIS-C. And right now, we don't have a good way to unravel that retrospectively. Of course, the good news that Dr. Tremoulet alluded to is that the treatment for both of those diseases, at least initially, starts off with IVIG. So that's the good news. Clearly, it's better to actually have a real diagnosis and not make a mistake and not confuse these, because the trajectory of these illnesses and probably the long-term effects of these illnesses are going to diverge. So we don't want to make a mistake. We hope that we are going to provide clinicians with the tools to be more accurate as we go forward. Audrey, do you want to add it?
No, just to echo that, I think personally, it was a learning curve. On every new patient that came in after April 27th of 2020, I think there was at least a 2 to 3 month period before I felt confident in what I was diagnosing. And that's after seeing a lot of Kawasaki disease and being able to review all those cases with Dr. Burns and other members of our KD group nationally. So I think that we as clinicians, as a group, have learned to distinguish these two illnesses much better. And we're using what we've learned to inform the diagnostic tests that we are developing in the hopes that we can, again, provide a platform to be able to distinguish these diseases better.
Okay, we have a question here for Dr. Dummer. COVID vaccine and myocarditis in children, and getting confused by all of this. How common is this? And are children with Kawasaki disease at a higher risk when they get this vaccine of getting some myocarditis?
That's a very good question. We are starting to gather information in our clinics when we see our patients who have had Kawasaki disease about whether or not they're vaccinated and how they tolerated the vaccine. So we obviously will know a lot more as time goes on. But so far, it seems like the patients we have seen with a history of Kawasaki disease have tolerated the vaccine without that particular side effect. At least at Rady Children's, we've had about 15 patients with the post-vaccine associated myocarditis, and none of them have had prior medical illnesses consistent with Kawasaki disease or underlying cardiac disease. So we don't know the exact information to that, but we believe it's likely that the children who have had Kawasaki disease will be at similar risk, which is very rare, to have that sort of a complication from the vaccine.
And maybe I'd like
to chime in and just say that it is a very rare complication. And we are working, Dr. Dummer is part of a national consortium funded by the NIH to study MIS-C patients. We are also beginning to use that same platform to study complications of vaccination. And none of our other sites, this is maybe 30 groups across the country, so major children's hospitals, no one is seeing any signal that suggests that Kawasaki disease patients will handle the vaccine any differently than any other child.
Okay, thank you very much. So we had a number of categories here, so we might switch just for fun to one of the other categories. So the questions came in the categories of COVID, obviously, and Kawasaki disease, treatment of Kawasaki cause, family issues, risk to siblings, and then long-term effects. So let's look for a minute at the family issue siblings. Here's a couple of our questions that were interesting. Any issues with an increased incidence of cancer or other serious disease in children who had Kawasaki disease during their childhood? Dr. Burns, do you want to start with that one?
Okay, I am going to sound,
I'm going to sound like a broken record and say, to answer that question,
we need the long-term.
We need the long-term study, and we need people to enroll, and we need people to help us answer that question. But based on our experience, and again, we collaborate with groups not only in the United States, but all over the world, with the group at Imperial College in London, Great Ormond Street, groups in Europe. So we're all talking to each other. I hope you get a sense that there's a very collaborative network of researchers throughout the world, Australia, Singapore. I mean, really, we have colleagues everywhere, and particularly in Japan, the country of highest incidence. And there is no signal currently that children with Kawasaki disease go on to develop any kind of subsequent problem at a greater frequency than the general population, with perhaps the exception of migraine headache, which is something that we're actively studying. We need bigger numbers. We need more of you to sign up for our adult KD study.
Okay, great. Dr. Tremoulet, is Kawasaki disease changing in any way? Are we seeing more Kawasaki disease that have heart involvement than we used to see? Or maybe we just have better techniques for diagnosing it? I'm not sure.
I don't think that we've seen a change per se. So one thing we have to remember is that in 2017, the definition of what's called an aneurysm was changed with the new guidelines for Kawasaki disease. So we may have reclassified some children. So maybe in your clinic, when you come and see us, we may say, you know, we called this before normal, now it's dilated, or we called it dilated, now it's an aneurysm. But that's true for only a handful of patients. I do think certainly techniques for evaluating the coronary arteries have improved. So someone diagnosed 20 years ago, we now have better techniques by echo and now by CT that we can visualize the coronaries better. And that's part of what we always aim to do with anybody that comes back to clinic, is to really try to look back in time and to see if there's any other better way to visualize the coronaries, especially now in young adults that have had aneurysms. That's why with the new CT scanner that we have at Rady Children's, we're excited to have launched this PEACH study and be able to better visualize the coronary arteries and to gather more data about how to treat these patients.
Okay, thanks very much. And then I think we have some cardiology questions here that Dr. Dummer might help us with. Do Kawasaki children who had Kawasaki disease and had dilated arteries, but they appear to have self-corrected, do these children require ongoing echoes as they get older? Where are we with long-term follow-ups and recommendations? You might also mention how, if they vary considerably across the United States, because I presume that we're still in a situation where we're learning more about and having better techniques for assessing it. So help us out.
Yes, sure. And Dr. Tremoulet and Dr. Burns should also hop in on this because they've been following these patients over time. But so it's interesting because at least in our clinic, when patients have had complete remodeling of their coronary arteries, which means that they might have started out dilated or aneurysmal, but over time, the arteries have come back to a normal lumen size. Those patients are still followed with imaging, depending on the frequency depends on how significant it was in the beginning. So that is probably different. So if you had a giant aneurysm that completely remodeled, we're going to be studying you with imaging techniques differently than if you had only mild dilation of an artery that then remodeled back to normal. So we still follow patients with echocardiograms to see the very proximal part of the vessels. But for many patients, what we're doing now is that at certain intervals, we are doing the coronary CT scan so that we can see distally the entire coronary artery as it courses around the heart and into the heart muscle. Because that is a part of the heart that is not seen very well by echo often. So we are certainly doing CT scans in patients who had a history of giant or large aneurysms. But other than that, we use echocardiograms to follow our patients. Now, it's debatable whether or not patients who had normal coronaries throughout their entire course and were treated adequately within 10 days, it's debatable if they need repeat imaging over time, long-term.
Okay, thanks very much. And then I don't think, unless I missed it, can you just also address whether children with a KD can participate in high impact sports? Do you give any restrictions, and does that just depend on the status of their coronary arteries, I presume?
Yes, yes. So it does depend on the status of their coronary arteries, not necessarily because of their coronary artery, but because of the treatments that we use. So for patients who have persistent aneurysms that are large or giant and are on anticoagulation, either warfarin or Lovenox or Apixaban, these newer anticoagulants, those children we do tend to restrict from exercise and sports that would risk high impact injuries and or joint injuries and such like that. So we usually restrict them from high collision sports and contact sports and things like that. For patients that are on aspirin therapy long-term, because their coronary arteries were not giant or large, but might have some residual dilation, they are not restricted from activities. We do not restrict patients that are on aspirin, or because they're on aspirin, we do not restrict them from exercise. And for patients that had Kawasaki disease and never had any heart involvement, they are not ever restricted from exercise. So the vast majority of our patients with Kawasaki disease are not restricted in their exercise.
Okay, thanks very much. And then we have just a short follow-up on perhaps related. Do you recommend aspirin for life in a child with the giant aneurysms?
So I think that would depend on the status of their coronary arteries at this point in time. So we generally, we modify the treatment of patients with giant aneurysm based on where we get them to remodel. And so some patients have had giant aneurysms and required the systemic anticoagulation agents like Coumadin, Lovenox, Apixaban, but then over time have remodeled to a point where we're comfortable enough with antiplatelet agents, which would be aspirin and or Plavix. So it just depends on what the status is of the lumen of the vessel at this time.
All right, thanks very much. Dr. Tremoulet, we have a question here that you, I'm sure, are interested in and probably have some information for us. What's been happening with cases of Kawasaki disease outside of the United States?
And so there's also, just as noted from the data that we have analyzed with Dr. Burney, there's also been a decrease and a decline in the number of Kawasaki patients, as far as we know, throughout Latin America. And the MISC has reared its ugly head and is still plaguing much of Latin America, even more so than here in the US. So we are actively working across Latin America. I have the pleasure of running a network. And for many of those parents that are on, I've had questions in Spanish in the chat. I want to thank those families for joining us from Latin America as well. But it does appear that Kawasaki disease may be following a similar trend, but we need to look into that further.
Okay, and then a very easy question for Professor Burney here. Do you think that COVID-related illnesses, including MISC, will provide an important clue to the cause of Kawasaki disease?
Dr. Burns, I think Dr. Burney is left.
All right, well, I will, I work on the team with Professor Burney, so I will attempt to answer that for her, but I think the answer is yes. I think that one, if we can call it a silver lining of the pandemic, is that we have been handed a huge clue, because behavior changes, decrease in pollution from automobiles. I mean, there were so many factors in the environment and in our behavior that changed during the pandemic. Maybe it was multifactorial, maybe there was one of those changes that was key, but the aggregate effect of all the things that changed during the pandemic made Kawasaki disease almost, but not quite, disappear. And that is a huge, huge clue. So the climate team is looking at environmental factors, at the idea that perhaps we should be doing aerosol monitoring or sampling within the houses of particularly young babies who get Kawasaki disease, really a focus on the environment with Mike Levine, Professor Levine and his group at Imperial College. They've been analyzing the throat swabs. If you came into Rady Children's Hospital through the emergency room, you would have gotten a throat swab. Part of that was used maybe for ruling out strep infection. But the other part of the swab, if you were participating in our research, actually went to England, where all of the microbes that were on that swab were extracted, isolated, and now are being analyzed. And we're looking at what was up here in your throat, in your mouth, at the time that you developed Kawasaki disease. And then how might that have changed during the pandemic? So we're taking a multi-pronged approach to try to understand the effects of the pandemic on the severe and marked decline in KD cases, and now the resurgence of Kawasaki disease. So in the last couple of weeks, Dr. Tremoulet and I have admitted several Kawasaki disease patients. It's back, it's coming back. And what is it about our behavior, the environment that's changed that has caused it now to resurge? These are huge clues. Let's just hope we're smart enough to read the tea leaves and figure this out.
All right, and I think a final question before our break would be this is a question that's sort of come for the world with COVID, and that is the best way to support children who've had Kawasaki disease, but who appear to have a prolonged recovery. And I think, you know, we've now had certainly experienced that with what has been called long COVID. But I think that there are some children with Kawasaki disease who also have had prolonged symptoms and a longer time than we hoped for them to recover. Any thoughts about that? Who would like to take that? Who would like to start with that? Audrey, how about a few words?
So I guess I'm just trying to understand the question. So is it, you know, what kind of medical support or emotional support can be provided, you know, and it also, I guess, regards to if this is KD that's happening now as to before. So we certainly have some children where it takes them longer to recover from Kawasaki disease. You know, some kids, they leave the hospital and at the 2-week visit, they're fine. But some of the older kids, especially teenagers who may have been, you know, involved in sports activities, may have some limitations and may feel really run down. So I think it's important to have a conversation with your physician about what's going on. Like, if there's still inflammation in the blood work, is that why that child is still feeling run down and hasn't physically gotten back up to normal activities? And it may also be a disruption in their mental and emotional health. We all acknowledge that being hospitalized is a traumatic experience. Children regress. We all regress after we've been through such trauma. These last 18 months are proof of that. So we have to just acknowledge that difficulty that everyone's going through with that admission, and be able to, you know, provide a safety net for those kids so that they can get back up and running. And so just even acknowledging that it's a difficult process for these kids, I think, is really part of that, and bringing them back to their normal lives, whatever that is right now.
Thanks. I agree, but I think that this prolonged COVID that we're seeing in children, particularly the older children, will be helpful in terms of understanding what ways to help people who've developed, you know, a serious but mysterious and serious illness at the same time. Well, I think it's time for us to take a Zoom break. And we are supposed to take that Zoom break between 10:30 and 10:45 San Diego time. So that's a little less than 15 minutes, and then we get back together again.
And during that time, I think if we can get the tech to work, Amelia was going to show you guys a brief news segment that was done recently by a family that we cared for at Rady Children's who had MIS-C. The parents were, well, the mom was only partially vaccinated. The father was unvaccinated at the time the child had MIS-C. The child was not eligible for vaccine. And through that experience, they really came to understand the importance of vaccination and wanted to spread that word. So she will share that segment. And then also, hopefully, she can put up the QR code. So if anybody has photos of their child that they would like to provide consent and share those pictures with the KD Foundation for the diagnostic tool development that we're doing, that is also greatly appreciated. Thank you.
System inflammatory syndrome, also known as MIS.
We start feeling really bad, really sad.
The parents of a local 8-year-old boy are warning others about the dangers of COVID-19 after the boy contracted a rare disease from being exposed. Good evening and thanks for joining us. I'm Marcella Lee. The boy is currently being treated at Rady Children's Hospital for multi-system inflammatory syndrome, also known as MIS-C. The condition is associated with inflammation in the body, which in some cases can be deadly. News 8's Shannon Handy has more on his story, including why his parents say they blame themselves because they are not vaccinated.
8-year-old Eduardo Cortez has been here at Rady Children's Hospital since Saturday. Now, while his condition has improved dramatically, he was very sick. His parents say they wish they would have taken COVID more seriously.
He was really sick.
For nearly a week, Leo and Rosa Cortez haven't left their son Eduardo's side. They took him to Rady Children's Hospital on Saturday with a high fever, but never envisioned he'd still be here.
I thought it was just like a fever, a normal fever, but everything was increasing.
The 8-year-old was diagnosed with multi-system inflammatory syndrome, or MIS-C, a rare but serious condition that affects children exposed to COVID. MIS-C is a brand new disease. It was discovered in April of 2020 in the United Kingdom. Since then, there have been about 4,000 cases in the United States, 80 of them at Rady's. Though no local children have died from MIS-C, nationally, the mortality rate in the U.S. is between 3 to 5%.
Kids are coming in with fever, they develop rash, some red eyes, some neck pain and swelling of the neck. They get severe abdominal pain as well. It also causes inflammation of the heart.
Dr. Adriana Tremoulet says Eduardo has exhibited all of those symptoms. At one point, his temperature reached 105 degrees. His treatment included steroids and other anti-inflammatory medications. In most cases, MIS-C affects children 8 to 14, about 2 to 6 weeks after they've been exposed to COVID. Eduardo's parents had COVID in early August. Leo isn't vaccinated. His wife has only had 1 dose.
It's because we don't think that this is not going to happen to us. Now we understand now that this is a wrong decision that we took.
Leo and Rosa are sharing their story in hopes of convincing others to get the vaccine, which they intend to do, saying if they could go back in time, they would.
It already happened to me, and I don't want to happen to anybody else. especially for the kids.
Eduardo will be released in the next few days, at which point he will be monitored as doctors try and figure out the long-term effects of MIS-C.
You ever
It is 10:45. I think next session starts. Dr. Barnes, would you like to introduce Kate?
Okay.
It is my
It is my pleasure to introduce Kate Davila, who I first met many decades ago when she was sharing her experience of Kawasaki disease, with an assembled audience at the first Parent Kawasaki Disease Symposium in Boston, Massachusetts, many decades ago. And since that time, Kate has gone on to become an amazing advocate, a peer educator, a resource that we use all the time for our young adults who need to reach out to someone for advice, someone who's been in their shoes, so to speak. And so it's a wonderful pleasure and honor to have you here, Kate, representing the KD Foundation. So thank you for joining us today.
Thank you for having me. Let me just share my screen. And there we go. So I just wanted to introduce myself. My name is Kate Davila, and I am the current Vice President of the Kawasaki Disease Foundation. Just really quickly, for those of you who may not know, the Kawasaki Disease Foundation was formed in October 2000 by a group of parents and professionals. The foundation was a byproduct of the highly successful Kawasaki Disease Parents Education Symposium, which was sponsored by Children's Hospital Boston and the Heart Council at Children's Hospital. The event was able to bring together more than 150 parents from around the US and Canada to learn the most current and accurate information available from a team of internationally recognized experts, as well as to promote peer support among families and patients. Our mission with the Kawasaki Disease Foundation is to strive to be at the forefront of KD issues by uniting the personal insight of families with the expertise of medical professionals. KDF's mission is based on 3 basic principles. Raising awareness among the medical community, childcare providers, and the general public is critical to early diagnosis and treatment. Facilitating support among families is essential to help families cope with this uncommon illness and the potentially devastating effects of heart damage. And increasing funding for research is necessary to advance diagnostic guidelines, enhance the existing treatment, improve short-term and long-term follow-up care, and find a cause. And the Kawasaki Disease Foundation represents a true collaboration of parents and medical professionals. Our board of directors consists of parents whose children who have had Kawasaki disease and individuals affected by the disease, medical professionals who are recognized as KD experts, and volunteers from around the US who contribute a significant amount of time and effort to support the organization. I have been involved with the foundation since its inception in 2000. I attended that first symposium because, as Dr. Burns had said, I had Kawasaki disease at the age of 15 many decades ago, as she pointed out, and back in 1993. While at the event, I was able to meet many parents and doctors, and one of the people who I met at the time was Greg Chin. Greg's familiarity with Kawasaki disease came about because his son Taylor had been diagnosed in 1998 at the age of 3. His family's experience was much like that of other families. Taylor developed a high fever, rash, swollen lymph nodes, and over the course of a few days had many visits and check-ins with medical professionals. After many tests, he was admitted to Children's Hospital Boston, finally diagnosed with Kawasaki disease and treated. Fortunately, Taylor did not suffer any heart damage, and today he is an active, healthy young man. Greg and his wife Meryl were extremely grateful for the outcome, but knew that many children were not so lucky, leading them to participate in the symposium and eventually start the foundation, with the mission of helping to fund Kawasaki disease research and find the answers needed not only to diagnose and find the cause of KD, but also to help discover the long-term outcomes of kids who have had KD, whether they had visible heart damage or not.
Greg Chin. My son Taylor had Kawasaki disease when he was just 3 years old. Fortunately, he was diagnosed and treated in time, so we expect him to lead a full and active life. Unfortunately, for many other children, the outcome has not been as positive. Kids of all ages have suffered heart damage or died because this disease wasn't recognized or treated in time. The message here is painfully clear. We must act now before we lose another child like Nathan Hill. But we can't do this without your help. Your financial support in underwriting this film and other awareness programs will help save precious lives. Awareness can make a difference. It did for my family. Please contact the Kawasaki Disease Foundation to pledge your support. Thank you.
Now that video was produced back during that first ever symposium back in 2000. It's on YouTube. You can find it as well as on the foundation website. Greg has spent the past 21 years, though, with the foundation as its president, working to fulfill its mission, raise awareness and funding to support research, as well as partnering with KD researchers and physicians to help them fulfill their mission of finding the cause of KD and developing a diagnostic test. Some of the major milestones throughout his tenure do include co-sponsoring Kawasaki disease symposiums in Japan, Hawaii, and San Diego, helping with various educational events around the US, co-hosting multiple fundraising events, donations to KD research at UCSD and Seattle Children's Hospital, and the establishment of Kawasaki Disease Awareness Day, which takes place every year on January 26th, marking the day, January 26, 1961, when Dr. Kawasaki saw his first patient with the telltale signs of what would later be named Kawasaki disease. Greg has selflessly given his time and efforts to the foundation throughout the years. With his help and leadership, the foundation has truly made a difference in the world and in helping further the cause of KD awareness. Over the past 20 years, over $500,000 has been donated to KD research. 19 educational Kawasaki disease parent symposiums have been hosted at no cost to its attendees across the US. And since 2011, we have been able to distribute more than 45,000 KD symptom posters at no cost around the US. And 11 KD days have occurred since the designation of National KD Awareness Day. Greg continues to inspire a new generation of KD board members, and recently the foundation added a KDF youth group whose mission is to further educate young adults, teens, and tweens on Kawasaki disease, since so many of those KD kids whose parents have been involved with the foundation are now teens, tweens, and young adults themselves. It's impossible to put into words the true impact Greg has had on the KD community. These words that some of our board members have said can only begin to express the appreciation that we have for him and his dedication to the KDF mission and finding out the answers about Kawasaki disease. We are all truly grateful for his leadership and so very thankful for his commitment and perseverance over the years. And we also wanted to note Greg is not going anywhere. We wouldn't let him because he's so important to our organization. He's staying on the board as our treasurer, but he's just stepping down out of the president's role, and Vanessa has taken over as president, and myself as vice president, and Catherine Frank has stayed on as our secretary. So I appreciate being here and being able to present this information, as well as honor Greg in a small way.
And I would just like to add my thank you to Greg and the incredible role that he's played in sponsoring all of these educational efforts for parents across the country and really across the world. The KD poster that was created by the foundation is a wonderful educational tool. There are so many ways that he's made the difference in the lives of so many people. We'll never know really his impact, but we are hugely, hugely grateful for his service, his friendship, his colleagueship, and his ushering the KD Foundation into a new era. So thank you, Greg. I would now like to introduce our adult KD speaker. This is a tradition that we started several years ago when we realized that the personal narrative of adults who had gone through Kawasaki disease were instructive, but also had a very personal message for our children and the parents of our KD children that, yes, you do grow up to adulthood and you do have a normal life. Professor Halsey was an integral part of my training as a resident in pediatrics at the University of Colorado. And he was the infectious disease fellow at that time. He was the person we called when there were patients with possible infections that we needed help with. And we are all connected in a very interesting way because Dr. Glaudet was also my mentor at that time at the University of Colorado. So we are a transmission lineage of information and scholarship. And it was a great surprise to myself and to John Gordon, who is the adult cardiologist, interventionalist, very involved with our adult KD team, to learn from Neal that he had had a medical problem. And I should mention that Dr. Halsey went on to have an extremely distinguished career as the head of a vaccine institute at Johns Hopkins University, where he was a professor for many, many years and only recently retired. But with that introduction, thank you, Neal, so much for joining us today. And we all look forward to hearing your very unusual story. Thank you.
Thank you very much, Jane. I'll turn my video on for just a moment so you can see what I really look like rather than my idealized photograph that you posted earlier. I'm very happy to share my experience, and because I think it might help some of you later on as you may develop some other issues. Most people have turned their video off, and I'm going to do the same right now. We'll turn it back on, for the questions. But I think my story may be of help to some of you, especially parents of children who did develop aneurysms or people who developed aneurysms at a later age. I'm now 76 years old. I'm retired, but I'm a professor emeritus. That means I work but don't get paid for much of the work at Hopkins. And but I continue to be involved in infectious diseases, vaccines, and vaccine preventable diseases. I wanted to say I, and I think the others on this call, all hope that someday Kawasaki disease will be prevented from a vaccine, perhaps through some of the research that everybody's participating in now. I did have Kawasaki disease at some time in the past, but we simply don't know when. I have what's called missed Kawasaki disease. I'm quite fortunate that my problems were uncovered before I had a major cardiac event. So my story, I'll start it 2.5 years ago, and that's when I had a CT scan of my chest as a follow-up for a lung problem that is associated with some difficulty swallowing and some intermittent aspiration of fluids. So I had some changes in my lung, and the radiologist recommended follow-up CT scans at yearly intervals for 2 years. The second follow-up scan, the radiologist included an incidental note that there were severe calcifications in my coronary arteries, which I found a bit alarming because I thought it was relatively healthy. as did my internist, who did refer me to a cardiologist. I'm a fairly active person and had a reasonably good diet, only slightly overweight as compared to some of my siblings, I would say. And I exercised regularly. I was able to do, 30 minutes of workout on an elliptical about 5 days a week, mowed my lawn in about 45 minutes, a moderate sized lawn. But my cardiologist, my internist and my cardiologist really felt that there was probably nothing to this finding in the CT scan because they, knew me. I didn't have a cardiologist before the referral. And the cardiologist said that, it's very unusual for an incidental finding to ever lead to anything significant. But I told him that over the previous 6 months, I had noticed decreased exercise tolerance, decreased endurance for doing things. I ended up stopping workouts because after, 5-10 minutes, I would get tired and I would notice some chest tightness, which I attributed to the lung problems that I had. And I had to break up the mowing of my lawn into 3 15-minute segments with a rest period in between. And I was concerned about that. So he reluctantly agreed to do a stress test, but he told me he thought the results would be normal. So with the stress test, you get on the treadmill, they put an EKG monitor on you, and then gradually increase the effort that you undergo and look for changes in the EKG. They asked me to report any symptoms that I had. After 2 to 3 minutes, they asked me how I was doing. I said, fine. After about 4 to 5 minutes, they said, do you have any symptoms? I said, yeah, a little bit. And on a scale of 10, I rated them at, 2 to 3. And we kept going. And then after about 4 minutes, maybe 5 minutes or so, they asked me any change. And I had some increase. I rated the chest tightness as a 3 to 4 out of a 10. I said, it's been much worse than that. The two people doing the stress test, looked at each other, then looked at the EKG monitor carefully. One grabbed the back of my belt and the other one turned off the machine and carefully sat me down in a chair, looked hard at the EKG monitor again, and then called my cardiologist and told them there were significant changes indicating decreased blood flow to major coronary arteries. So that led to some further tests. You don't need to know all of the things that were done, but a decision made that I had changes and substantial changes in at least one coronary artery. So what the standard practice is, you get angiography where they inject dye into the coronary arteries, look for the narrowing, and then inject this, and then insert a stent over the narrowing, which they assumed was at one location. So I underwent the cardiac catheterization. They give you a mild sedation, but you're fully awake and can engage in the discussion. After the first injection, the little chatter that was taking place between the guy doing the injections and the physician, interpreting everything, stopped. They were quiet, and then they repositioned the catheter, did a second injection, and then a third injection. And then he announced, he says, we're done here. And he pulled out the catheter, told me he'd be back in a few minutes. He left the room. I'm sure they were all looking at the images that they were taking all along as they were doing it. When he came back into the room, he said that I had large coronary aneurysms in 3 of my arteries, my coronary arteries, and that I would need to have bypass surgery. He said he'd already talked to a surgeon who would be coming in a few minutes. Surgeon came in. I said, well, I'm not excited about getting bypass surgery. And he says, no, you need it, and you need it fairly soon. There was 80 to 90% narrowing in my left anterior descending artery, major coronary artery. And so I said, okay, well, I had to rearrange a lot of things that I was doing, but about a week later, I underwent bypass surgery. The bypass surgery went fine. There weren't any problems. They bypassed all 3 of the involved vessels, not just the one with 80 to 90% obstruction, but 2 of them that had about 50% obstruction, which apparently is the standard in somebody who met that profile. After the surgery, the surgeon told me in the follow-up meeting after I was out of the hospital, he said, we get about 2 to 3 people a year who have, quite healthy looking hearts, which yours is, but who have significant narrowing and with some aneurysms. So you're a little unusual. We do, I can't remember the number he said, they do hundreds, if not a couple thousand of these bypass surgeries amongst all the cardiac surgeons at Johns Hopkins, where I was there. At the time of the catheterization, when he told me I had the aneurysms, I told the angiographer, I said that, aneurysms are associated with Kawasaki disease. I know this disease well. It's Dr. Glaudet, who probably supervised me when I was a fellow, but even earlier than that, during my residency, I'd seen cases, and I've been involved in the care of about 15 to 20. Dr. Glaudet and Dr. Burns have been my regular source of follow-up information about Kawasaki disease, at least on a yearly basis when I'd see them at meetings. So they played a significant role in my education about this disease. And Dr. Glaudet helped me out when I first went to Johns Hopkins, and I was the first person at Hopkins to treat a patient with Kawasaki disease with IVIG. Dr. Glaudet had been doing some of the key study that evaluated the benefits of IVIG, and she shared that with me prior to the publication. And it was an interesting situation at Hopkins and quite controversial, but I insisted on treating them. The cardiac surgeon nor the angiographer had really seen patients with Kawasaki disease. They just dealt with adults. They hadn't dealt with the children, so they were not familiar with disease. I learned that I had made a mistake. I really should have consulted both of them before I had my surgery, but as you can imagine, I was reorganizing my life and planning for the cardiac surgery because the management probably should have been different, knowing that I had aneurysms. They should have, when they did the catheterization, I'm told by Dr. Gordon that they can do an intravascular ultrasound, and then they can study the aneurysms and the dimensions and so forth, and look carefully and determine whether or not you can put in a stent. I'm not an expert in that area, and I would defer to them to explain more to you. But by doing the bypass surgery, especially with vein grafts and the 2 lesser effective arteries, you can run into problems after surgery with early failures of the bypass graft that takes place, and then sudden myocardial infarction or a blood clot in the coronary artery. And so I believe they would tell you that I probably shouldn't have had the surgery in those 2. And it took them about 3 months to convince me, but patients like me who've had that surgery should be on stronger anticoagulant or blood thinner therapy in order to prevent those myocardial infarction. And so they did convince me, and I'm now taking Eliquis and aspirin. I'm doing fine on that regimen, but truthfully, I didn't want to do it because of the potential risks associated with those things. So I'm doing well. I've recovered. I'm back doing my exercise. I was mowing my lawn regularly, but now I'm hiring the neighborhood kids to do it again. And so, but I'm still exercising, and I'm doing most of the other things that I had done before the surgery. I'd be happy to take questions during the Q&A period, but thanks to Dr. Burns and John Gordon for their assistance with helping me out. The message, I think, is that if and when you or your children later in life do develop the usual progression and buildup of atherosclerosis, or those plaques that we all get in our arteries, you may run into trouble, but the management might be different than it would be for most patients that are seen by cardiologists. So thank you for listening to the story, and look forward to the discussion.
Neal, thank you so much for sharing your story with us. It's always instructive for us to hear about outcomes. And of course, we're all thrilled that you're doing well and delighted that you're on systemic anticoagulation.
I'm still not delighted, but I'm on them. So,
so that's a good segue into Dr. Dummer, who is a pediatric cardiologist, but also getting increasingly involved with our long-term outcome study. And this is a topic that is near and dear to her heart as she takes on the care of all of our aneurysm patients who are still children, who are now being treated with the same therapy that Dr. Halsey just shared with us. So thank you so much, Neal. Don't go away, because there may be questions that come up in the Q&A and in the chat that we want to call on you to address. So stick with us. And it's now my pleasure to introduce Dr. Dummer, again, pediatric cardiologist, who's going to talk to us about a better way of treating children who have giant aneurysms instead of giving them rat poison. She's going to talk about the alternative. Thank you.
Thank you so much for having me today. I am here today to talk about Kawasaki disease and the newer agents that are called direct oral anticoagulants. As we just heard, Eliquis is one of them. So we will talk about the application in our patients. So Kawasaki disease causes inflammation in the coronary arteries and the heart muscle, and it is the leading cause of heart disease in the United States and Japan. And even despite timely treatment with IVIG, about 1% of the patients develop giant coronary aneurysms. And giant coronary aneurysms are defined by an absolute dimension and or by a Z-score, which is kind of an average of an average. And so these are vessels that are quite large compared to the size that they should be. These pictures here depict an angiogram. So these are when dye is injected into the coronary vessels. The coronary vessels bring blood flow and nutrients to the heart muscle. So they are what keep our heart muscle strong and healthy. And on the left of the screen here is a picture of normal vessels, which have very smooth walls. And you can see that they taper or become smaller as they course around the heart. The picture on the right is an angiogram that depicts multiple aneurysms or ballooning of the walls of these vessels. They become very irregular and larger than they should be. And sometimes during remodeling, you can see that there are areas of aneurysms and areas of narrowing called stenoses. And this is a major complication associated with Kawasaki disease. The reason why this is very important is because of what Dr. Halsey just alluded to, is that when patients have these aneurysms, it affects the way that the blood flows through the vessel. And so the blood tends to slow down in those areas of aneurysm. And those vessels are at much higher risk of getting clot formation in them. And so that results in a heart attack or ischemia. And so that's why these are very important to know about and diagnose in Kawasaki disease so that we can treat them with certain blood thinners. I'm just going to play a part of this video that I know we've alluded to in the talks here today.
An elusive infectious agent is suspected as the culprit. We do know that the body responds with inflammation that can damage the blood vessels that supply blood to the child's heart. The resulting weaknesses in these arterial walls can balloon and form aneurysms where clots can build up. This can result in heart attack, possibly even death.
So the conventional therapy that is agreed upon across the world, there's consensus that patients with giant aneurysms need to be on blood thinners. And what we mean by that is they need to be on systemic anticoagulation, which means that it's a very strong medicine that thins the blood, and antiplatelet agents. So the blood thinners that are used when this happens in the acute phase of Kawasaki disease are warfarin or Coumadin, or low molecular weight heparin, which is called enoxaparin or Lovenox. This is a little injection that's given. And the patients are also on antiplatelet agents such as aspirin or Plavix. So we're going to talk about these particular medicines that are used in the acute phase. This picture on the left here is a picture of how systemic anticoagulation works. And so we have different proteins in our body that helps us to clot. And when we use various medications, they prevent these proteins from working the way that they are supposed to work and make clot. And so warfarin or Coumadin affects 3 or 4 different proteins to inhibit clot formation. Enoxaparin and heparin work similarly, also directly on, this is thrombin here, to prevent clot. The newer agents, which are over here called the DOACs, direct oral anticoagulants, like Apixaban, which is Eliquis, and some other similar medications, are acting here on this protein that inhibits the 10A, which is what is used as an enzyme to help another protein called thrombin make clot. So if you inhibit this, then the body is less likely to make clot. On the right here is a picture of what happens with our antiplatelet agents. So this is the inside of a vessel, and the red blood cells come down the vessel. And when the endothelial junctions are injured, like occurs in Kawasaki disease, the platelets are sticky and they want to come and stick where the injury is. So aspirin is used very commonly, and that prevents the platelets from clumping together. Some patients are on aspirin and clopidogrel or Plavix, and Plavix prevents the platelets from actually sticking to the area of injury. So we use both systemic anticoagulation and antiplatelet agents to get at 2 different ways to help prevent the body from clotting in that area of aneurysm. So warfarin was very commonly used for many decades and remains the mainstay of therapy in lots of countries, and actually different places in our own country. It's a difficult medication to manage because patients on warfarin require very specific dosing to keep them in a very specific range, a very specific lab level called the INR. And that helps us to know how thin the blood is with our medication. And it can be very difficult to manage in children. There's multiple interactions with different dietary items and with other medications such as antibiotics, which are commonly used in children. So it can be troublesome to manage well in children. The other aspect of Coumadin or warfarin that we know about is that it causes systemic calcification, which is calcium that builds up in various vessels in our body. And that includes the coronary vessels and vessels that are out in the periphery of our body. And that's because warfarin works against vitamin K, and vitamin K is used for different things in our body, including some of the processing of this calcium. And so patients who are on long-term warfarin can have calcification build up in some of their vessels. And that by itself, vascular calcification, has been associated with increased risk of heart problems and death in adults who have plaque buildup. So despite the fact that that's a bit of a different disease than Kawasaki disease, we have some concerns that long-term warfarin is probably not the best agent in our patients with Kawasaki disease with aneurysms. And this is a picture of a CT scan that's looking at the coronaries. And so this is the aortic root here, and this is a picture of the left coronary system. And you'll see here on the far left, this is normal. The middle picture shows some of this brightness, which is actually calcium that is built up in the vessel walls. And then on the far right-hand side of the screen, you'll see that this is a lot of calcium that is built up in the vessel walls. And so this is what we worry about long-term. We worry that this is accelerated in patients who are on warfarin for a long period of time. So in San Diego and with Dr. Burns and Dr. Tremolet's group of patients that they follow, they have been using direct oral anticoagulants in this small number of patients with aneurysms once they are out of the acute phase. So the children are still treated with warfarin or Lovenox in the very acute phase, but then many of our patients have now transitioned over to these newer medications, these selective factor 10A inhibitors. They're good for a number of reasons, one of which is that they work very quickly, so there's a rapid onset of action. They have a short half-life, so the medication that we use most commonly, which is Apixaban or Eliquis is what it's called, is used twice a day. There are other medications that can be used once a day, and some of the adults are on those. It doesn't require any lab monitoring. So this can really impact quality of life because the patients are not having to go to the lab once a week or have home monitoring or go to the lab once a month. And so this is a great option in children. And the dosing has been established by the pharmaceutical company that makes this particular medication. And so there's specific dosing for children versus adults. We know that it's efficient and safe. It's been studied in a few non-Kawasaki disease states, and it's currently being studied broadly in children with heart disease. And so that data from those studies will be out, but we feel like it already has been demonstrated to be efficient and safe in children, and we've had some good outcomes in our patients. So we have about 25 patients that are on the direct oral anticoagulants. 21 of them are adults and 4 of them are children. All of these patients have giant aneurysms, so they're both on the oral anticoagulant and the antiplatelet agents. The children range in age from 4 is our youngest on Eliquis to 13 years of age. And it's been very well tolerated. We've had one patient with recurrent nosebleeds. And so that would be what we call, a bleeding adverse event, but it wasn't major, didn't require transfusion or surgery. But we've had no major serious bleeding events. And the average duration of therapy for these patients that we follow is about 4 years, but up to 8 years. And so not a lot of bleeding problems and seems to be highly effective at keeping the blood thin and the vessels open. I just want to remind everybody for families and patients who have had giant aneurysms that a med alert bracelet would be important. And we always talk about making sure that families and caregivers are trained in CPR. We provide a medical summary for each of our patients with giant aneurysms that the kids carry them, give them to the school nurses, take them to their colleges, families keep a copy of it. So that it can be quickly referred to in a time of emergency. And the symptoms related to having not enough blood flow to the heart muscle generally is acute onset in chest pain. And we're not talking about a little twinge, we're talking about very significant and unusual chest pain that occurs in a child or adolescent. And in infants, it can be a bit more difficult because obviously they don't talk and can't express themselves, but they often present, if they're going to, with decreased blood flow to the heart with feeding intolerance, rapid breathing, they're pale, they're clammy, and they're very irritable and in pain, essentially. So we all ask our families to know who their local emergency room is, so have a plan about exactly where you're going to go if any of these disturbing symptoms occur. to call 911 and call the Kawasaki team, at least our patients here, so that we can alert the teams that will be receiving the patients and to give an additional dose of aspirin right at the time of the 911 call. So we try to review this in clinic with our patients each time that we see them with giant aneurysms. So that's the end of my talk. I want to acknowledge the team at Rady's and across the world, really, who partner with us to take care of our patients and our families. Thank you for listening. Happy to take questions.
There we go. So we would like to invite Dr. Glaudet to come back, and we've got another 30 minutes for questions. Dr. Dummer, thank you so much for sharing that information. And if people have specific questions about the systemic anticoagulation that they're on, one route that I would recommend is to see your cardiologist and have your cardiologist contact Dr. Dummer. This isn't something that you're going to go out and change on your own. This is a process of educating our colleagues across the country about changes in management that are now possible and can be a great advantage for our patients. So encourage your cardiologist, if you're on a different regimen, but you'd like to know more about the direct oral anticoagulants, encourage your cardiologist to actually contact Dr. Dummer at Rady Children's Hospital, and I'm sure she'd be happy to talk with and provide information about these newer agents. So I'm going to mute myself and turn it back over to Dr. Glaudet, and we can all maybe turn on our cameras who might be answering questions, and we await.
Okay, thanks very much. We'll start through these questions again. Thanks very much, Kirsten and Neal, for your good information to us. We had some questions come in through the chat, and I'm going to try those. And I'm not sure who this question is for. Perhaps Dr. Tremoulet can start us off. This is a question about the immunologic distinction between Kawasaki disease and MIS-C in terms of differences in cytokines and inflammatory response, but maybe you can just share a few thoughts on distinction between Kawasaki disease and MIS-C.
Yeah, I responded quickly to that as much as I could in the chat, but I'm happy to elaborate. So
good.
We've done some initial work in that arena, and there is an inflammatory response in MIS-C that in many ways looks like what's happening in acute Kawasaki disease, but just more severe, more inflammation. But similar pathways that can be blocked by drugs such as infliximab and anakinra are really elevated in MIS-C and more elevated in MIS-C than in Kawasaki disease. So as I wrote back to that particular person, we're still learning a lot more to investigate, and I'm sure we'll have updates, certainly by next year at the same symposium.
Maybe I can chime in a little bit too. Our patients have donated their blood for our research, and that blood can be interrogated to burst all the cells so that they release their RNA content, and then to profile what were the cells thinking. And when we do that, we actually see very dramatic differences between Kawasaki disease and MIS-C. So even though at the protein level, which would be cytokines and chemokines, these inflammation mediating molecules that circulate in the bloodstream, at that level, there, as Dr. Tremoulet said, there's a great deal of overlap with the MIS-C patients just looking more so. When you actually get into the cells and look at what they were thinking, what they were really responding to, the differences are dramatic. And it's very easy, in fact, to separate those two groups of patients. So we're learning more about that. A lot of this work, particularly the larger numbers of samples, have been analyzed through our collaboration with Professor Levine at Imperial College in London. And we are working on diagnostic tests from that information, but also trying to wrap our heads around what this message really means, that at the RNA level, these diseases look so different. So that's part of ongoing research. So stay tuned. We certainly don't have the full answer to that question yet, but I think we now have a handle on it. And the next few months are going to be very full of new information.
Okay, we have a short, quick question, I think, perhaps for Dr. Dummer. A child had Kawasaki disease 7 years ago, and he's on aspirin. Any particular precautions, particularly related in this case, the question was for swimming?
No, there are no precautions. I assume if your child is on aspirin, that means that there is minimal residual dilation of the vessel, and we do not restrict our patients. He should swim away.
Okay, sounds great. Best way, perhaps, we'll ask Dr. Burns to take this one. In her experience, what are the best ways to support our children who have had an atypical prolonged recovery period from Kawasaki disease?
So I think I want to re-emphasize what was mentioned earlier in the Q&A, that we don't really recognize a physiologic long-term problem after Kawasaki disease, and that prolonged recovery may be on two different levels, so emotional, psychological. And then I also wanted this opportunity to bring up a problem that we see not infrequently in our clinic, which I like to call fragile child syndrome. And this is not actually a problem of the patient, it's a problem of the parent. And I'm a mother and a grandmother, I get it. Your child has been very sick, and there's a normal tendency to treat them or think about them differently than your other children, or to unconsciously restrict or worry or treat them as though they are fragile in some way. But they are not. And you are actually doing them a huge disservice. And this is not just our experience of our patients in our clinic, but there actually have been some studies by Annette Baker at Boston Children's Hospital and others who have done psychological intake testing and surveys of parents and seen this phenomenon of the fragile child. So if you think your child's having a prolonged period of recovery from Kawasaki disease, I would really focus on two issues. One, is your child needing support, fearful or concerned about their own bodies because of the trauma of hospitalization? That has nothing to do with Kawasaki disease per se. It has to do with a young person being in a situation that they don't understand, that they can't intellectually grasp, where people did things that hurt them, that frightened them. Blood drawing, all of these procedures are noxious for all of us, but if you can't understand why it's being done, it's frightening. So some of these children need counseling with appropriate play therapists or an appropriate age group, appropriate psychologist, and psychological or emotional support to work through their concerns, their feelings, their fears. So that's one avenue to think about with your child. The other avenue is to look at yourself and do some introspection about, are you actually aiding and abetting a concept of fragility, of ill health, of weakness that you unconsciously are passing on to your child. So I think those are the two arenas where I really think some attention might need to be paid. We do not recognize, in the absence of severe coronary disease or having had a heart attack, we do not recognize any kind of exercise limitation or physical problem in recovering from Kawasaki disease. And the recovery by 1 or 2 months is complete, should be complete in all patients. So I think look elsewhere for a problem.
Okay, great. I think this has probably been covered between our story of Dr. Halsey and Dr. Dummer, but are we making progress from a cardiac surgery or cardiac intervention point of view, again, in the sort of giant aneurysm, very difficult situation? Is there anything else on the horizon here that's going to help us with this situation? Besides anticoagulation and vigilance?
I don't know if Jane or Audrey wants to talk about statin use. I mean, we're studying that in the PEACH study, but there was another question in the chat about should all patients with giant aneurysms be on statins? And what is our thought about the aid in remodeling? It's a question to the other panelists.
Audrey, do you want to pick that one up?
Well, I would say that's the motivation for the PEACH study. And I think that the data that we have from the laboratory, where we take cells and we expose those cells in a dish to serum, blood samples from KD patients before and after statin treatment, are quite remarkable in showing that the cells look healthier after being exposed to Kawasaki serum from patients treated with atorvastatin. So I think there's scientific rationale for that. And we've shown that atorvastatin is safe down to very young children. So that's exactly why we've embarked on the PEACH study. And I think that is a potential avenue for reducing the risk of damage to the endothelium, as what happened with Dr. Halsey. So we hope that we can reduce that risk.
The other place, yeah, go ahead, Jean.
I was just going to add that our adult Kawasaki disease team has 100% of its patients on a statin, atorvastatin, or other members of that family, not specifically for the cholesterol lowering effect, but rather for the anti-inflammatory and promoting endothelial cell health aspect. So sometimes we do things in medical practice before we have the giant randomized study that shows us that, yes, of course, this is strong evidence that this is what we should be doing. But the experiments that Dr. Tremoulet was describing, where we do things in the laboratory in an artificial system with cultured cells, human cells, is a way of trying to short track that process. There will never be a randomized trial of atorvastatin in children or adults with giant aneurysms after Kawasaki disease. So we want to weigh risks versus benefits, as we do with every treatment that we give to our patients. And at this point in time, I would say that the overwhelming circumstantial evidence is in favor of using atorvastatin for all patients with giant aneurysms. And that is what we're doing. And Dr. Tremoulet has been involved with a study in Japan, the country of highest incidence of Kawasaki disease in the world, with examining the safety and tolerability of statins in populations of Kawasaki disease patients with aneurysms in that country. So I think once you establish that it's safe and it's well tolerated, then we have to use these other methods in the laboratory to bolster up the concept that it's also desirable to use these in our patient population. So I think that's where we are at this point in time. And I doubt that we're ever going to have the substantial, robust clinical trial evidence to get us beyond that point.
Maybe if I can just add a little bit, for adults who have aneurysm, it's a no-brainer to use a statin. I'm on a statin. Statins are recommended for everybody over a certain cut point. I can't remember what age, but because they have reduced mortality, and that's in the absence of Kawasaki disease. If you've had Kawasaki disease, if you have any aneurysm of any size, you are at some increased risk of the narrowing. And as I mentioned in my summary of my own illness, I mean, all of us, have progressive changes in the endothelium and the narrowing of our coronary arteries. And if you've already started with some narrowing, you don't want any more narrowing. So it's easy. I mean, and I'm not a cardiologist, just a patient, but everybody as an adult who has any aneurysm should be on a statin. That's simple. You can answer the question for pediatrics. I mean, you can do the research there, but adults, nobody would even suggest any studies.
Okay, thank you very much. All right, we're back to some vaccine questions here, and I think that we're in a new era here where we're moving this vaccine into younger and younger children gradually and importantly, and we hope to do it safely. But I guess the question is, are COVID vaccines safe for children under 12, particularly children relative to this symposium who have a history of Kawasaki disease? Are there any concerns about that from anyone's point of view? Jane, want to start?
I can certainly start off
and say that there will not be recommendations to give younger children vaccines until it has been studied, reviewed, and deemed to be safe. So I, like everyone else on this planet, is waiting for the experts to tell me when it is safe, what dose should be used. We don't recognize right now that there's a difference among the vaccines. That was a question that I saw as well in the Q&A. So maybe differences will emerge over time. We currently have a suggestion that the Moderna RNA version of the vaccine is a little bit longer lasting than the Pfizer. So over time, these are new vaccines. We will learn more about potential minor differences among the vaccines. But I will follow the recommendations of experts because we believe that experts have our best interest in mind. And everything that we pass on to our patients is based on the consensus of experts in this field. I'm not an expert in this field. Dr. Tremoulet is not an expert in this field, but we listen to experts because we need their help and their advice and their guidance, and we follow it. And so when the vaccine is available, we will recommend it for that age group. And Dr. Halsey has his hand up as someone who has worked with vaccines and dedicated his entire career to vaccines. So Neal, please weigh in.
Yes, and also for the last 25 years, I've focused on vaccine safety. I am carefully monitoring the studies on the COVID-19 vaccines in children. you may not know, but Pfizer has already scheduled a meeting with the FDA Advisory Committee seeking emergency use authorization for 5 to 11-year-olds. The studies my colleagues at Johns Hopkins did participate in those studies. They've used a lower dose than the dose in the adults on the assumption that they may need a lower dose. We already know from the information that's public that the younger children responded very well to that lower dose as well or better than the adult dose, and there are no new safety issues. And the information from Pfizer is that the adverse event profile is actually a little bit better than what it was with the second dose, for adults. So there's not been an increased risk with booster doses, and the risk in the children is not any, there's no evidence of an increased risk in the general pediatric population, but I haven't seen all the data. We will see that in 2 or 3 weeks when Pfizer presents it. But the difference in the vaccines is going to be the timing of the availability. Moderna is behind by just a couple of weeks, I believe, in terms of getting their data together. It may be a little longer than that. So if you're trying to get your children vaccinated early, the difference will be what's the availability. The AstraZeneca's vaccine is less effective, and certainly I would want, and I am already protected with the Moderna vaccine, I would choose either the Pfizer or the Moderna. You can't make a decision, but I can with it.
Dr. Grode, you're muted.
Yes, sorry, yes. I saw a question in the chat that I wanted to read, but now my chat is gone from the front of me here. Okay. The issue is, the question in the chat was an interesting one about if Kawasaki disease is an inflammatory condition and might be occurring in children genetically programmed to respond to inflammation in a certain way. What about the hypothesis that these children then, when they either get vaccine, particularly COVID vaccine, or another illness, might also have an increased inflammatory response to that's genetically inherited in their body? Who would like to comment on that?
I can take a first pass.
And
I guess I would say that
we're studying the genetics of Kawasaki disease, and there's no question that there is a genetic underpinning to this. And it likely has something to do with inflammatory pathways, calcium signaling pathways, et cetera. What we have not observed, however, is any unusual reaction to vaccines, so the general childhood vaccines, which are mandated, I would add, in all children in order to go to school. There's a mandate for vaccines that has been widely accepted in this country since the smallpox vaccine was first mandated in 1913. So mandates are not new for vaccines, and they have been widely accepted. And Kawasaki disease children, like all other children, get those vaccines and don't have a problem. So there's no evidence that a vaccine would trigger an unusual immunologic response. And beyond that, they go on and get other seasonal illnesses and do not seem overall as a population to have any unusual reaction to other infections that they encounter during the course of their childhood or young adulthood. So I don't think that the concerns are warranted, that there's anything special about global immune responses in Kawasaki disease children. There obviously was something about the specific trigger for your child, and we think there are probably a finite number of different triggers, and your child's specific genetic destiny cause them to have a very weird and very dramatic response to that one trigger. It does not spill over into other antigenic triggers that they encounter in their life. So no concerns. Do you want to add anything to that, Audrey?
No, I have nothing else to add. I don't know if Dr. Halsey has any other information, but I think that I agree that the concern is not there given what we know about Kawasaki disease.
Okay, a question for Dr. Dummer. Can you have a normal life if you have been diagnosed with Kawasaki disease at 1 year of life?
Yes, I mean, we have no reason to believe otherwise. So with the current medical therapies and diagnostic tools, at 1 year of age, even though you may be in a higher risk category for X, Y, or Z, we would imagine that you can lead a normal life.
Okay. For Dr. Tremoulet, any new treatments on the horizon for the affected coronary artery, either, to prevent it initially, some new treatment methods versus later? Any thoughts?
So new treatments, I'm trying to think, there are no new trials that we're trying to do right now for different treatments than what I've talked about. What we are working on trying to get funded and currently sits with the CORI, Patient-Centered Outcomes Research Institute, is a grant application that our team and the team at Boston Children's with Kevin Friedman, we've applied for a grant to do a clinical trial comparing IVIG plus infliximab versus IVIG plus steroids for children with coronary artery aneurysms. I think we still have an unanswered question as to which combination therapy is better for coronary artery aneurysms. And I think that question, even though it's not a novel treatment, that's a very important question that needs to be answered. And that's where we're focusing right now for upcoming studies.
I might add that our group, and in collaboration with John Shee, who's a vascular biologist here, we are searching for truly novel ways of approaching the damage to the vessel in acute Kawasaki disease. I think we all share the idea that we have to jump in fast and we have to jump in aggressively right at the beginning. So we have one moment in time to make a difference in a child's life and trajectory of their health. And it's at that moment when we diagnose that they have early damage to the heart by echo and they're presenting with their acute Kawasaki disease. So studies with John Shee's group are looking at metabolic functions of the endothelial cells and how their biology is being altered in the acute phase, and some prospects for drugs that are available that could alter that or improve that. And those are completely new avenues of research that would bring in a whole group of drugs, of medicines that are approved or being used for other indications, but might be repurposed to help children with Kawasaki disease. But I would say those are several years away of making their way into the clinic, but an exciting frontier that we're involved in, and we'll see where that goes.
Okay, a question for Dr. Tremoulet. Does Kawasaki disease affect the immune system negatively? My child, who had KD, gets sick a lot more than his younger sibling.
I think with that question, I would echo what Dr. Burns mentioned earlier, that we don't think there's any spillover effect There's no chink in the armor, as we say, in terms of the general immune system for children with Kawasaki disease. If anything, after kids receive IVIG, that initial 11 months to a year when IVIG is still in the system, we actually hear from most parents that their kids do beautifully well. And those with young children in preschool or kindergarten school age kids have less infections because of the protection from IVIG, but nothing in terms of long-term immunological issues that we know of.
All right, then we had a question for Dr. Burns. How common is it for KD patients to later have sudden hearing loss?
So this is an issue that we became aware of in the 1980s when I was at Boston Children's Hospital, and we published several papers where we did longitudinal studies during the acute and subacute phase of hearing evaluations in children, because we had become aware of a very rare complication of acute, sudden sensory neural hearing loss, which means that the nerves that actually take the signals from the ears back to the brain and vice versa were being affected or could be affected. That nerve runs through a very narrow channel in the bone, and if there's a little bit of swelling, that can compress the nerve. That might be one route in which this damage was being mediated. It also could have to do with little blood vessels that were supplying those nerves. We don't really know why it happened, but it clearly was a very rare complication. Much less than 1% of children experience this kind of very severe hearing loss. So it's devastating when it occurs, but thankfully it's very, very rare. And we do not routinely recommend any kind of hearing evaluation in children after Kawasaki disease. That said, infants, of course, may be preverbal at the time they have Kawasaki disease. And if there were ever a question about speech delay, meaning a delay in a child beginning to use words, the first thing that everyone should think of, and all pediatricians would, of course, think of this, would be a problem with hearing that therefore is interfering with their learning speech and speech development. So if your child after Kawasaki disease has some problem that might raise the issue of hearing loss, of course it should be evaluated. But hearing loss happens independent of Kawasaki disease, and that's probably a much more common event than the subacute phase, acute hearing loss, sensory neural hearing loss, that is clearly, but very, very rarely related to Kawasaki disease.
Okay, great. And this may turn out to be our final question for Dr. Tremoulet. Can one episode of Kawasaki disease cause elevated fevers for all future illnesses, even if unrelated? Example, ear infection, just a tendency toward the development of very high fevers.
So not that we know of, is the quick answer. We don't know of any increased fever risk or any risk for any of these infections or response to it being differently after Kawasaki disease.
So I think with that, I'm going to thank all of our panelists, all of our listeners, and a huge shout out to Lucia for the translation. Thank you so much. We want to be all inclusive with this information, and you've helped share with our Spanish only speaking population. So a huge, huge thank you. Also a shout out to Amelia Bento and Chisato Shimizu, but particularly Amelia, who takes on this effort every year of her own accord. And without Amelia, this would never happen. So huge thank you to Amelia. Chisato is also there supporting her. But I just want to say that we hope from the bottom of our hearts that you will get vaccinated and that next year we can all be back in person again. Because over the many decades that we've done this, it's been such a pleasure to see all of our families, to be reunited, to give hugs and celebrate that we are making progress, but to do it in person makes such a difference. And I sincerely hope that this time next year, we will be in person and we will have that wonderful opportunity to be together. Of course, we'll continue with this online recording because people can enjoy it over a cup of coffee 3 weeks from now. And that's important too. But I think we all miss the personal contact with you, our families, and hope that that can happen. So please stay safe, mask when it's appropriate, everybody get vaccinated, and we'll see you next year. Thank you to everyone.